Sir, you can start. Thank you.
Good evening, everyone. 8 years, 10 months old boy, first by birth order, born on 3rd April consecutive marriage, hailing from Gorakhpur, residing in Pen by relatives, brought by parents with complaints of fever and vomiting and weakness for a duration of 2 days, 10 days back, and weakness in upper limb since 3 days, weakness in bilateral lower limb since 2 days. Child was apparently all right 1 week back when he had complaints of fever, which was moderate, undocumented, not associated with chills, rashes, or rigors. Vomiting 3 to 4 episodes per day, non-bilious, non-projectile, containing food particles. 3 to 4 episodes in consistency, patches of blood or foul smelling. For these complaints, child had taken symptomatic treatment, after which symptoms got subsided. Later, that is on 27th April, 2 days before the onset of weakness, child had a fall on his back while playing with his friends, after which child had minimal back pain. There was no history of loss of consciousness or weakness of limb. 2 days post-fall, child had difficulty in lifting arms, feeding self, and holding glass, but could get up from the bed. He was able to walk without support, get up from squatting position, and also from supine position. 1 day later, child started experiencing weakness and pain in both lower limbs and required assistance for walking and getting up from supine position and squatting position. Child was able to appreciate touch, pain, and cold and hot. This progressed to unable to walk, turn in bed, or sit independently in 4 to 5 hours. With these complaints, he was taken to private practitioner on 29th April. There, the doctor suggested some investigation like cervical spine was, cervical X-ray was done, which was told to be normal. For these complaints, child was treated symptomatically. Later, child was referred to higher center next day. There was there is no history of fever or vomiting or loose current at present. No history of altered sensorium, irritability or convulsion. No history of bowel bladder involvement. No history of recurrent immunization or recent vaccinations or animal white. No history of drooling of saliva or inability to close eyes or regurgitation of food. No history of sweating or palpitation. No history of swelling or lower back. Birth history, preterm vaginal delivery at 8 months, twin pregnancy, birth weight of 1.5 kg, died immediately after birth, and I can stay for a duration of 1 week in view of very low birth weight. Twin A has history of iron, interrupting fetal death. Child is 29 till date, development-wise, child has attained normal milestone with good academic performance. Diet history consumes family pot mixed diet. This is the first child, second one, first child. Later child is older child is second child is 15 months old currently. There is no significant family history. Belongs to class 4 family as per modified Vijay Prasad scale.
So quickly, what you make of the first illness? You are vomiting loose stools. What do you make of that? Yes.
There's some preceding event following which there is development of weakness. So we'll have to localize. This could be at the level of the spinal cord.
No, I'm just saying first illness, fever, vomiting, loose stools. I thought you would have said it's a viral infection. Looks like a viral infection, maybe. So we'll come back to it later. Then there was a fall, and after 2 days of the fall, there's a weakness. Okay. 2 days after fall, child had difficulty in lifting arms, feeding cell. So now this weakness, you tell us what is the anatomy. Is it CNS? Is it peripheral nervous system? Is it upper motor neuron, lower motor neuron? What do you think is the anatomy? And then we'll correlate it to what has happened earlier. So this was one arm or both arms? Okay, so both upper limb weakness. So where could the anatomy be? Brain or spinal cord? Why not brain? Brain is also represented, no, both sides by the upper limb. You could have two lesions, one here, one there.
Other higher mental functions are normal.
Sorry.
Other higher mental functions like consciousness.
If you have a bilateral brain lesion, then it is possibly an extensive lesion. It should have affected sensory. So that is unlikely. So it is spinal cord. Okay. Now within the spinal cord, can you try and decide upper motor neuron or lower motor neuron?
Upper motor.
Why?
Upper limbs are involved.
Upper limb doesn't mean upper motor neuron.
Lesion could be above the cervical. Bilateral limbs are involved.
So first give me a prototype of upper motor neuron lesion in the spinal cord and a lower motor neuron lesion in the spinal cord. First give me a prototype, then we'll discuss. So what is the upper motor neuron lesion of the spinal cord which will cause weakness of both upper limbs? Okay, so transverse myelitis. And a lower motor neuron prototype? GPS. Now think of these two prototypes and tell us which one is this.
I think first, let's talk about the loose stools. Viral infection is not common at this. That's number one. Second is, high moderate or high fever is not often associated with viral diarrhea. Number three is, viral diarrhea is a profuse watery from the mouth. This is 3 to 4 times a day. So this but certainly it's not viral, but it's watery. So what is it likely to be? A typical toxic diarrhea could fool us with watery stools, and they may not further proceed with blood mucus like a typical bacillary dysentery. And many bacillary dysenteries also start with fever and 2-3 watery stools, and thereafter run into blood and mucus. So we keep it open. It will not matter a great deal. But looks like at this stage, it will not be easily taken it as a viral infection. But thereafter, what's happening is he fell down. Don't you think the rest of the neurological problem is a purely traumatic? He first fell down. We're discussing anything else. It's a traumatic problem. From that,
म्हणजे याची फाईल चेंज करणार आहे. झाल्या संग कमी करून
somebody has to mute, I suppose. You get my point? The first thing is a fall before the onset of weakness. So it's obviously a traumatic neurological injury. Any thoughts on
Agreed.
that?
So we could have gone either way. So I was trying to come to the anatomy and then ask you whether that anatomy is possible with the fall. Sir is asking you whether it's related to the fall. So tell us, is it possible that it is due to the fall?
So the question is, you should have asked how severe was the fall. Fall
Trivial trauma.
while playing,
Trivial trauma.
yeah, trivial trauma. While playing, okay. If it was from the height, it could have been severe. So this cannot be severe at all. So that means, then why did he fall down? Just a casually unrelated issue. And that puts you to say that, is this the first clue to the lower limb weakness? And that's why he fell down. Okay, so don't rush to start from upper limb and go down. Well, that can also happen in a GBS-like syndrome, but this suggests that it started with a lower. Okay, but it was easily noticed in the upper limb in terms of working. He had no problem getting up. That means the sitting or standing has not been involved. So it's only the periphery. So you come to a conclusion that it's likely that it started in the lower limb. We are not sure, but certainly it's.
The upper limb started. She's saying that he was able to walk without support even after the upper limb started and get up from squatting.
So probably then it was reversed. But I would say, why was the fall? Now, just because he was able to walk does not mean that he did not have a mind.
Should have been little more details of the fall. One could have a natural fall. If fall was the cause, which gave rise to such a severe weakness, the immediate phenomenon should have been more marked. If he did not get up, he had to be lifted, then only it can explain the subsequent development. I fell down, I was dancing, and suddenly 2 days later something happened. Cannot say.
So
And more
incidentally,
details about the fall. But I think somebody can just have a transient fall neurologically and can come better transiently. So we may not be able to consistently because the neurological events have occurred. Unless you say he was pushed by somebody or he was climbing and then it's under. So little bit of details about the
so what sir is saying here is for every history of a fall, try to ask whether there is an explanation available for the fall. This carpet was not proper, something was there, his leg got entangled and he fell, fine. But if for no reason he fell, then think whether that fall is also a neurological. So this is a habit you have to make for every fall ka history, right? I was asking, in which falls do you get neurological problems after a gap? Here we've got it after 2 days. So in which falls can this happen?
Surrounding hematoma, lead collection develops, then later we will be having symptoms.
Give examples.
Epidural.
Subdural. Okay, so that subdural will go on increasing at the time of injury. Nothing might be happened, maybe momentary, days or shock or whatever. And after some time, progressive CNS problems, right? So only such selected situations. Suppose there is a hematoma in the spine at the time of a fall. Do you think same story will happen? That fall, 2 days fine, and then that hematoma has caused a weakness. Do you think that will happen?
substance.
Why? Here also it's a slowly growing hematoma which has compressed 2 days later. So, give me better reason. The child won't be normal, na? Which kind of an injury can give rise to bleeding? You have to decide that. So if there is a progressive bleeding, there has to be a fracture there. If there's a fracture there, that child can't be normal for 2 days. There'll be severe pain, etc., etc. Right? Only in selected situations there'll be a interval like this. Otherwise, there won't be an interval.
Why subdural takes time and spinal doesn't? Spinal, rightly we said, if there is a bleeding, it will start manifesting very early. But subdural may take time. Why is that? It's an intracranial hemorrhage, no? And the reason is subdural hematoma is a venous bleed. And veins bleed slowly. Arteries have a force. So extradural, okay, or of course intracerebral would just make a child manifest very early, immediately. But a subdural takes time. And then the veins keep on bleeding slowly, and therefore the hematoma is small to begin with, then goes on increasing, and then the symptoms are due to raised ICT or also the pressure over the normal hemisphere of the body or the local level. And therefore it takes about maybe 48 hours before all this happens. And I think that is important in a subdural hematoma. You have to get to subdural hematoma and really evacuate it. If you allow 24 hours, that venous bleed has become big as a hematoma, and then it starts causing trouble. So that's the reason.
So we were saying anatomy and we were trying to decide LMN or UMN. Any further thoughts on that? In the spinal cord, we said. We were discussing, na, can it be transverse myelitis or can it be a GPS-like thing in the spinal cord? So tell me which one is more likely and why.
Oval bladder involvement is not there. Cranial nerve involvement is also not direct in history. So it might be also transfer myelitis.
Okay. So typically what happens in upper motor neuron lesion of the spinal cord?
Below the
Yeah, closer.
below the level of the lesion, the sensations will be absent. I mean,
And what happens to the motor part?
at the level LMN and below the level of the lesion UMN.
But is motor affected or not affected?
Affected.
So that's the point, no? So if you have a UMN lesion of the spinal cord, then below that, everywhere motor has to be affected. You can't have a segmental affection and then nothing below that. That is possible in LMN, but not in UMN, right? So if the lower limbs were definitely normal at that time, then that is a strong point against UMN and it makes it LMN, right? Besides, of course, the other reasons like splatter bowel or sensation or whatever, right?
After all, it's lower motor neuron lesion. Would it be anterior ones? Only upper limbs are picked up, and the other areas are not picked up. Typically, polio-like illness is exactly not symmetrical, not involving everything. So could it be anterior ones then? Could it be neuromuscular junction? Could it be the muscle itself? Could it be nerve? Why are we getting on to root straight on?
How do you
Anyway, come on, this is not difficult. We have done it a number of times. Come on, somebody. Why are you quiet today?
So the anterior horn cell, if that is affected, only purely the motor symptoms will be there. Later, the child has also developed pain, so that indicates sensory involvement also. Only a pure anterior horn cell involvement will have a bilateral anterior horn cell involvement seems less likely, given the preceding illness, and also the child has developed pain symptoms later. So root or nerve involvement is more likely.
Anterior horn generally is asymmetric. That's number one. Okay, though it could be symmetrical as well. That's not the thing. Then it is a little progressive for the first few days. And that is the typical of anterior horn cell. And today we don't see polio at all. So, but still, any other viral infection could do the same. But this is too symmetrical. And therefore it's unlikely anterior horn cell. It's about the muscle as well. It cannot be just localized like this on both sides. So that's out. What about the nerve? Again, a bilateral, symmetrical. Okay, so that's out. But now tell me that subsequently she said, I thought that there is no sensory loss at all. Correct? Then the root should have that. No? It looks like only motor. And only motor is only the muscle or an anterior cell or a neuromuscular junction. Neither the nerve nor the root. So if you're sure that there is no sensory loss, it has to be surely not root or nerve. Correct? So now why are we talking about GBS, etc.?
Neuromuscular pain is if it's a neuromuscular environment, it has to be a fluctuating weakness. That fluctuation of weakness is not, that history is not given. So neuromuscular seems to be less likely. And there can be pure motor involvement, pure axonal involvement in nerves. So it's not always necessary to have sensory involvement when there is a nerve nerve weakness.
Typical GBS has a very transient sensory loss. That's often not perceived by the patient. And by the time you get the patient, it has already disappeared. Therefore, it looks motor for all practical purposes, but it has also a transient. And what is typical of that? A pain. Of course, this fall is pain, etc. That's different. Therefore, the pain is one aspect of a sensation involved. But the rest of the sensation may be very transiently involved, and therefore it looks like more a motor disease. But really, there is still pain. And a typical root pain has to be there. It may be mild enough for a patient not to complain, but on examination you might find. And therefore, we still consider it as a root problem, neither nerve nor neuromuscular junction, muscle, anterior cell, etc. And then you have straight away an immune-mediated disorder after whatever that infection is. And therefore, a diagnosis becomes almost certain.
I thought history of backache should have been elicited because posterior root backache has to be there. So if you elicit the history, you might get a history that there was backache. We suppose the classical posterior radicular pattern.
Summary, 8-year, 10-month male child with 3-day history of progressive upper limb weakness followed by lower limb weakness for 2 days with preceding episode of fever, vomiting and loose stools, 1 week prior with history of trivial trauma with no sensory involvement and with no bowel bladder involvement, with preserved sensorium, with no cranial nerve involvement, with no significant family history, with normal birth and development is the case of quadriparesis to rule out Guillain-Barré syndrome, acute transverse myelitis, spinal cord compression, acute demyelinating encephalopathy.
Is it compulsory to give 4 diagnoses or not?
No, so let's debate between all four, no? So GPS we have already discussed. So what are the points in favor of acute transverse myelitis?
No cranial nerve.
No cranial nerve is not a point in favor. Means it's a very distant point. One or two things if you think which are really in favor.
Symmetrical weakness in acute transverse myelitis. Weakness could be asymmetrical.
Okay. Weakness would be asymmetrical. Anything else?
History of fever, vomiting, loose pills, 1 week back. That also.
Which is okay, which is not really pointing to transverse myelitis specifically.
Simple. Transverse myelitis is out here. Many points why it is out.
Okay, so one you said is segmental weakness. Then no obvious sensory involvement. Then
No bowel and bladder involvement.
okay, bowel and bladder involvement.
So a sharp sensation should, a band-like sensation should be there, below which.
Yeah, so there can be hyperesthesia
Hyperesthesia.
or something at the level of the lesion.
But that local thing is impossible for a patient to kind of complain. So that's only on examination, even that is not easy. But most important is, he was discussing below the lesion, the lower limbs have to be involved. Your first statement would have been, lower limbs are not involved. Forget the bladder bowel. Bladder bowel may or may not happen. You are right, bladder bowel as well, if it's an acute transverse myelitis. But what about the legs? That's the first reason you say it's not. Again, giving a differential diagnosis is not all causes of a spinal disorder. The examiner may not accept it easily. And in fact, you are put to more trouble to rule out every other one. So transverse myelitis need not be even thought of. And that is out. Right? What about spinal cord compression?
To tell us.
It was put because there is history of trivial trauma could be.
Correct. But now let's learn. So suppose we are talking of spinal cord compression. How will a spinal cord compression typically present? Forget this child. Then we'll come back to this child. What do you expect in a spinal cord compression?
Depends on where the compression, it depends on where the compressive force is from. It's an extramedullary region. Usually there'll be asymmetrical involvement. There'll be unilateral root pain, and the weakness will be more of a root type. If it's an intramedullary region, there will be bilateral involvement. The bladder bowel involvement will be earlier. So that will be, then we'll think of syringomyelia in those cases. And if it's an extradural compression, then we'll think of any epidural tumors, or the pattern of presentation will be different based on the compression.
Good. So that is, you talked of intramedullary and extramedullary, but you talked of acute compression or chronic compression?
Chronic compression.
Chronic. This one is chronic is anyway out because this has happened in 2 days. So if at all you are talking of acute spinal cord compression.
Then the sensory involvement, the pain, and the history of trauma will be significant.
But a TB spine may suddenly come with paraparesis. Okay. It may take time, but it could also be sudden. Then that means the compression can be sudden.
So how does TB spine come suddenly? Is TB sudden? Then what is sudden?
And what is the basis of every pathology? What happens suddenly is vascular. So it's the vasculitis. Okay, it's not compression. So word compression is out, but sometimes an acute vasculitis because of an adjoining tissue having a disease like any infection could have a vasculitic certain manifestation. So that is out. Compression is a time-taking story and therefore not even to be considered. What about demyelinating enzyme?
So as of now on history, we didn't get any enkephalon features. One. Then, yeah. So to that extent, in the spine, patchy is what it does look like, one's upper limb, one's lower limb, but there's no enkephalon involvement for sure, right? So if it's going to come up later, then you may keep it in mind, but otherwise, no.
Anyway, if it's the edema, maybe D or E. Though both of them are present often, but it could be D alone or it could be E alone. So could it be really only without encephalopathy? And the answer is again that at the upper level should have a lower limb involvement. There is no reason why only one segment is involved. Anything going down will be affected. And therefore, even that is not. And to my mind, really, all 2, 3, 4 are not even to be considered. But when you give an examination such thing, you are talking about all theoretical causes. But the examiner wants to know what is most likely in this and in this situation. Therefore, so before we go now further, one of you will tell me what neurological findings you will expect.
So in exam, as sir said, at the most you can speak in this language that my provisional diagnosis is GBS. Other differentials like acute transverse myelitis are not likely because, and then 1, 2, 3, 4. Spinal cord compression not likely 1, 2, 3, 4. That.
On examination, child was conscious, alert, apical with pulse rate of 86 beats per minute, RR of 30. RR of 30 per minute, saturation 99%, peripheral pulses were well fed, extremities walk, blood pressure of 120 by 79 mmHg between 50th to 90th centile. Head to toe examination, head was normal, trunk normal, abdomen normal, spine normal, genitals normal, extremities normal. There were like no lesions on the skin or on the back. Anthropometry wise, weight of the child is 34 kg between +1 to +2 standard deviation. Height 143 centimeter between +1 to +2 standard deviation. BMI 18, impression normal. Systemic examination, higher mental functions were intact. Cranial nerve examination, second nerve, direct right reflex present. 3, 4, 6 nerve, there are no abnormal eye movements. Fifth nerve normal. There is no deviation of face, but there is inability to close eye tightly and inability to whistle. Ninth and 10th nerve, there is weak gag reflex and nasal twang was present. Shoulder shrug was present. Weakness, no tongue deviation. Tone of all 4 limbs are normal. Power, neck, there was like power of 2 by 5. In upper limb, shoulder showed power of 2 by 5 in both right and left upper limb. At elbow, there was power of 3 by 5 in both right and left upper limb. In lower limb, all the power was 2 by 5 in both upper right and left lower limb. Reflexes, deep tendon reflex were absent. Abdominal cremastic reflex were also absent. Single breath count of 14. Diaphragm splinting was positive. There were no meningeal signs of irritation. Sensory system was intact. Straight leg rising test was positive. Cerebellum could not be accessed. Rest all examination were within normal limit.
So, interpret your findings, whatever findings you got. Cranial nerves, what is our interpretation?
Ninth and 10th involvement because element type.
Why do you know element?
If it is had it been UMN, the gag reflex should have been brisk or more aggressive, more vigorous.
Okay. And what about inability to close eyes tightly and inability to whistle?
Facial involvement.
Facial involvement?
I'd like to check it.
Okay. And
करा हाँ?
yeah. So we'll have to check that again and whether, sometimes it's not a complete paralysis. So you may get some signs, you may not get some signs. So you'll have to check that out.
So it's an intracranial disease. Cranial nerves are involved. No? And we are all talking about spinal. Okay. Right from 7 mile maybe. Okay. Down there, 9, 10, 11, everything is involved. So I think you have an extensive lesion, intracranial. That explains everything. No? Why do you want to go to spinal cord?
The nucleus of 9th and 10th are at the medulla. So it is infranuclear after exit involvement. So element.
Peripheral nervous system. Fourth will be extracranial.
So they are saying that the cranial nerves are involved after they've exited the cranium. And that is why it's lower. It's not an intracranial problem. Huh?
Bulbar involvement.
See, clinically, you cannot easily decide whether it is nuclear or infraneural. You can decide upper motor neuron or lower motor neuron. But if it is lower motor neuron, it could be at the level of nucleus or lower down. Sometimes, based on other findings, you may be able to say, okay, these 2-3 cranial nerve nuclei lie close to each other and they are affected. So it is nuclear, but that part is difficult. So I think that's not the answer why it is not intracranial.
High mental functions are different.
Higher mental functions are intact.
It is not involved. Have a lower center. I think you can pick up exactly the whole route in a 7. For example, if 7 is nuclear, 6 and 7 go together. Cerebellum is there at a cerebellopontine angle. So if you have a 6 and 7 and a cerebellum involvement, then you have typically just exit cerebellopontine angle. Thereafter, it goes to the internal auditory nerve. And I think that's a very important point to pick up because that's a very small canal. And if it's an inflamed nerve, that's the only type of a facial palsy which may not recover. And sometimes you may need even steroids. The rest of the thing will not be problem. Patient will almost always recover completely. So how will we know that it's caught up in the internal auditory nerve? It's a small area. And a little swelling of that nerve will possibly abut against the bones and it will cause definitely some neuro paralysis. So how will you know that? And therefore tingling numbness. Every time facial, you ask for that. In an exam, you might get only facial nerve paralysis. And they will ask you exactly tell us where it is. And when it comes out of stylomastid foramen, then there is some reason out there, like a parotid tumor, for example. But the fact that both eyes are involved and seem to be mildly open. If I say cannot close, then I will say keeps mildly open. That might mean that a part of lower motor neuron is involved. And that could be intracranial as well. The other, we cannot make out intracranial or extracranial.
Okay, analyze the motor system. So you have a weakness all over, which is nearly similar, right? And you have reflexes absent. So where is the anatomy? So tell me, out of the 5 parts of the lower motor system, lower motor neuron system, where do you get reflexes absent?
Anterior horn.
Anterior horn cell and
Neuropet.
no. So this one is anterior horn cell or no? Why?
No.
So how do you clinically recognize anterior horn cell?
Power. In case of anterior horn cell, power will be absolutely floppy.
Very good. So in anterior horn cell, power affection is plus, plus, plus. So significant weakness is anterior horn cell. In a nerve, it would be better. So that's how you differentiate between the two, right? Okay, diaphragm splinting positive means what? What was the tone? Normal. Abdominal and cremasteric reflex is absent means what? I thought superficial reflexes are absent in upper motor neuron or lower motor neuron? Upper motor neuron. So whole program has gone haywire. We were talking all nonsense and this is upper motor neuron disease. Or reflexes are not absent, one of the two. Or third possibility. Come on, quick. A reflex has what arcs? So afferent and efferent. And afferent is sensory. And we said sensory may be affected, but subtly. So that is the reason why these reflexes are absent. Not because of UM. Okay. Single breath count 4. So single breath count 14 means what? Bad, good, okay.
Not bad, not good. मतलब around 20 it should be normal. 14 is slightly different.
Around 20 should be normal. So, I'm just asking you, what is the thought process behind? Why that magic figure of 20? So, what are you testing in single breath count? Respiration, nahi. Be more specific. respiratory muscle involvement, effort of breathing. Is that what you're testing? What is the patient doing or not doing when he is counting 1, 2, 3, 4, 5, 6, 7, 8, 9, 10?
He's holding his breath.
Is holding his breath. Okay. Now take it further. How long can a 2-year-old hold breath and how long can a 10-year-old hold breath? It will depend on what? One parameter. FPC or even the rate. You can judge by the rate. No? So if your rate is 12 per minute, that means one breath in 5 seconds. So you can hold on for 10 seconds, nothing will go wrong. But if your rate is 40 per minute, then you can't hold on for 10 seconds. Something like that. So this is a rough way to judge. Okay, and then how much time will you take to count 1 to 10 or 1 to 20?
Actually, there is nothing like what is normal breath count. It all depends on whether you have been practicing. Those who practice yoga could have 50, 80. So it's not 12 or 20 normal or abnormal. What you should have said is, voice is poor in intensity. That's your first step. And then you say that to monitor his further progress, I have done a breath. So if he's improving, is he now from 14 gone up to 20? Then I'm in. So that is exactly because the respiratory muscles must work better to produce sound. And therefore, you should have said voice is poor in intensity, and therefore I have done a count. And is that count normal? There is nothing like normal or abnormal. It all depends on what is practicing, how strong he is, but for monitoring purpose. And I think that's where, because you mentioned it, I would ask you.
Also, you talk when you are exhale. You cannot inhale and talk. That means you have taken a deep breath first and then you are exhaling and talking. So if your deep breath is not deep enough, then your speech is affected. Cannot exhale and talk.
Interrupted speech. If some asthmatic calls me on the phone, he'll say, Doctor, I'm a bit breathless. Interrupted speech. Okay, so you could have mentioned that. I just wanted you to, because sometimes the examiner will ask you something that will upset your thinking. Don't mention that.
Diaphragm splinting positive means what?
Nasal. Distress. Why?
No, nasal flaring and distress is a different topic altogether. You say use of accessory muscles of respiration present. That tells you there's respiratory distress. When you say diaphragm splinting positive, means first of all, what are we trying to look at when we are actually splinting diaphragm? How are we splinting diaphragm? And positive means what do we want to convey? Is, what? Yeah.
Accessory muscles of respiration was used.
No, so that doesn't mean diaphragm splinting. Who will talk of diaphragm splinting? How will you bring the wheelchair here? We'll have to make space. Yeah, we can go then.
Go on both sides. This side doesn't matter. Read it also, so that everybody will have a look at it.
इसको अकेले को क्यों भेजा? So they have to be on the. Chalo, speak.
Is comfortably in position. Thinking normal. Child is normally breathing, is not in distress. There is no nasal flaring.
Yeah, so just now there is no distress. Now we were talking of diaphragm splinting. So what were we trying to say?
There are two.
Somebody will hold the mic.
There are two elements in the bill. One is intercostal and one is diaphragm. If I want intercostals not to work, then I must put the chest. The intercostals are not allowed to expand. So only the diaphragm. That means the diaphragm, when the diaphragm contracts, it goes down and the abdomen. So in inspiration, the abdomen will come up. Even if the intercostals are not working, the abdominal muscle, abdominal movements will not work. Now, I don't allow the abdomen to expand and I hold it from here. That means I'm not allowing the diaphragm to come down. And diaphragm contributes to 80% of your breathing. If you don't allow the diaphragm to come down, then only the movement of the intercostals will track. And the patient will be more breathless because the intercostal is going to play a smaller role in breathing than diaphragm. If I splint the diaphragm, the patient becomes a bit more breathless. And it is a warning that if his diaphragm is gone, he may become breathless anytime. It does not take much time for this particular child to become out of breath. While if I splint the intercostal and diaphragm is working, then I'm relatively happy. So just now I will splint the intercostals. Abdomen is moving. Yes, in fact, it's moving better than before. I am not still able to compress it as well, not allowing any muscles of abdominal muscles, not the diaphragm. Please note that my hands are also where the diaphragm is there and all the abdomen. See whether his intercostals are working to a certain extent. He still pushes my hands out because of the diaphragm. आपको ऐसा करने पर ज्यादा तकलीफ है कि ठीक है? He's not so much affected and therefore he's not much disturbed whether his diaphragm or. But this is the way because diaphragm, and also look at the diaphragm. Before you touch him, when a person breathes, the stomach must go up because the diaphragm is not. If he breathes and only this is coming and the diaphragm is in fact the abdomen is going down, that means his diaphragm is. If somebody breathes like that and abdomen does not come up, in fact, it goes down to the water sign, that the diaphragm. So don't even have to do any manual, just look at him and if the stomach is not coming out, you are warned.
So in exam, maybe you don't say diaphragm splinting positive because we don't understand what you want. You convey exactly that after splinting the diaphragm, intercostals are good, okay, or bad, and vice versa. Okay.
Before you look at respiratory muscle, ask him to take a deep. If he cannot take a deep breath, then your maneuvers have to be very, very cautious. Because if they are near zero, one of them, particularly diaphragm, if he's only living on intercostal, then you try to kind of splint diaphragm, he may suddenly get really very less. So ask him to take a deep breath. बेटा लंबा सांस ले ले, लंबा सांस ले ले. कितना लंबा सांस लेते हैं? ऐसे करो, शाबाश, छोड़ दो, फिर ले लो बेटा, फिर ले लो, शाबाश. Diaphragms are moving, but certainly not as good as.
भैया पेट को आगे करके सांस, जोर से सांस लो, पेट को भी आगे करो, ले लो, इसे पेट को भी आगे करो, जैसे not able to do so well, but he's doing it independently for the chest and abdomen. But just because the abdominal muscles are coming out doesn't mean that you may just do it with the abdominal muscle. You should breathe and then the abdominal.
Instruction facial symmetry is normal. इधर देखो, फिर से करना है, इधर इधर फिर से करना है, इधर इधर फिर से we couldn't close it. पूरा आँख बंद करो, जोर से बंद करो, इसलिए ओपन दूसरा जैसे आते हैं ना, जैसे
So when you told him to lift his hand, what did he do?
He's taking support, sir.
And very good. He's using the trunk. So these are all compensatory movements to try and achieve more movement. So you must observe all that, right?
It is normal, right? So the tone normal. Hypotonia. Hypotonia. हाँ इधर दर्द होता है दर्द. नहीं leave it. But he was quite flappy. So he's hypotonic, right? Is normal tone acceptable in a nerve or nerve root lesion? It is low motor neuron, no? There must be a hypotonia.
2 days history. He has started recovering, but on presentation, he was having normal tone.
No, so sir is asking you want this child to have normal tone or hypotone?
Hypotonia.
The point is, hypotonia is predominant also in anterior horn cell. The power is terribly lost. Reflexes are all. When you come up to nerve, certainly reflexes are lost. The power may also be lost to whatever extent, but tone may not be obviously hypertonic. And this kind of a flappiness may be related to normal also. Okay, or of course malnutrition, the most common. But even when your collagen tissues are not that strong, you could like a marfan. Okay, it may not be marfan, but something of that kind where you may have a little easy hypotonia or extension or flexion is much more easy. So be careful. Examiner will always show you the wrist tapping and will say, oh, it's hypotonia. That may not be so. But normal tone is acceptable. Only thing is you will have to say whether it's normal or abnormal. That is all, right? Good.
One show the reflexes.
सक्षम मोरे ना मराठी बोलतोस हिंदी बात करतो मोरे ओके
Reflex.
Affected to a certain extent, but when he did speak loudly, it was fair, but the articulation was not that.
कहाँ उठाओ बेटा? So this leg, your technique is not correct. You have to eliminate everything at the knee before you look at the ankle, right? So, yeah, best is to cross the leg in the sitting position. If you have to do, then cross the leg.
It's reflect. Well,
Okay? Thank you.
And like, sir, if diaphragmatic involvement is there, so that means the phrenic nerve is involved.
So phrenic nerve as in phrenic nerve is the specific nerve going to the diaphragm. But the fibers are coming from C4, no? So if there is anything wrong in the spinal cord also, it will get affected.
happens if phrenic is gone.
Paradoxical respiration. Paradoxical respiration, like on inspiration, the abdomen should come out, but it goes inward.
Will the diaphragm change its position? It will be where it is. It's paralyzed.
It be down.
No paralysis, where will be the diaphragm? Normal, down or up? Go up. It will go up.
Contraction
and the
produces
problem is,
coming out.
if an infant has a phrenic nerve problem and the liver will not be palpable, then the examiner will ask you, in an infant, normally the liver is palpable. No? And then you will find that the upper border has gone up, which means the diaphragm has gone up. Okay. And in what other condition diaphragm is up? One is phrenic nerve. What?
Abdominal tumor.
No, it's pushing up, but it's not really. Eventration of diaphragm. Okay. It's not paralyzed diaphragm, but eventration.
But like in the muscle charting which she has shown, so she has shown that the power of the upper limb and the lower limb are the same. I mean, both 2/5. So, sir, like if it is high cervical cord transverse myelitis, then like, can we consider on the power affected?
It's not just based on power, no? It has to be reflexes and everything.
And sphincter is an important part of transverse spine. Sometimes some transient sphincter distress can be there in PPS for a short time, but not a prominent. And also level, sensory. Sudhara. Jaldi Ram.
Diagnosis: symmetrical progressive quadriparesis with truncal weakness with bulbar cranial nerve involvement, with areflexia, without bowel bladder involvement, without sensory involvement, without encephalopathy, without meningeal signs, most likely Guillain-Barré syndrome.
Online, someone has said Miller Fisher. So exam going. What is Miller Fisher?
Involved, third nerve involved, then there will be attacks, and
Okay.
tingling sensation.
Okay. And someone has asked, what about Georgia? So do you expect anything to go wrong with the Georgia? And
It would be normal. It would be normal in case of humanity. UMN, it might be exaggerated.
so you expect it in UMN, but not here. How are you treating this child?
After child was admitted in the ward, he was shifted to PICU. He was shifted to PICU and started on IVIG. He was on room air till now. After 5 days of IVIG, child has started showing improvement. Power has also been improved and reflex are also present.
Did you do SLR? You have written, but you are not.
Yes, sir. On straight leg rising test, child had a back pain.
What
And
does it
also
mean?
on flexor aspect of thigh, also child had pain.
What does it mean?
Radicular pain.
Radicalized. It's a very important test to be done in suspected GPS. It's positive and it may help to localize the lesion to radicals, posterior radicals.
To confirm the diagnosis,
That's all. Most like
antibody,
no, we had got that of the child. But before that only we had started with IVIG. MRI showed cauda and nerve root enhancement. And the EMG NCV we had done. Yesterday report is awaited. CSF we had not done.
confirmation is today by MRI, which shows inflammation of the roots. And obviously it is non-infective inflammation. Therefore it's autoimmune. Therefore you may have to treat with IVIG or whatever. And therefore that's the only way. Antibodies have no question at all, no use. Even EMG, NCV also have no role. But specific, if at all you want to confirm it, it's an MRI showing inflammation.
Thank you, sir.
3 years old male child, third by birth order, born out of third degree consanguineous marriage, resident of Aurangabad, presented with complaints of fever since 1 week, abdominal distension since 4 days, vomiting 3 episodes 4 days back, yellowish discoloration since 2 days. Child developed fever 8 days back, which was on and off, low grade, undocumented, intermittent, not associated with rash, chills, rigor, dull during interfebrile. Abdominal distension was generalized, progressive, no positional variation. Vomiting had 2 to 3 episodes, small quantity, non-bilious, non-projectile, containing food particles, not associated with blood. For above complaints, fever, vomiting, and distension, took to some local hospitals where some blood investigations were done and child was referred to higher center. At that higher center, he was admitted for 4 days. Symptomatic treatment was started. On second day of admission, mother noticed yellowish discoloration. The same day, child was preferring to sleep and taken to another higher center. Over next 24 hours, child was responding only to painful stimuli and was brought to our hospital. History of similar complaint of abdominal distension, 2 episodes, 6 months and 3 months back, for which some symptomatic medications were taken. Significant family history. History of similar complaints in sibling, elder sister at the age of 2.5 years. Fever, abdominal distension, and jaundice, was admitted for 7 days. 1 year back, the sibling had history of abnormal gait and difficulty in walking, was admitted to some private hospital and evaluated for the same. Some urine investigations were done, which was told to be normal, and genetic testing were advised.
So tell us what are your thoughts on the chief complaints? Low grade undocumented fever. Now, we've made this comment many times that if the fever is low grade, then there's no point in talking about dull during interfebrile period. Okay? Interfebrile period is what? Period between two high peaks of fever. If fever is low grade, then there's no interfebrile period as such. Okay? And partially relieved again is very difficult because if it is low grade, then how do you say whether it's relieved or not? So these are all applicable only to high grade fever. So anyway, what do you make out of this low grade fever?
Viral etiology, mostly viral etiology present with low grade fever.
Okay, so viral etiology presents with low grade fever. So can viral etiology present with high grade fever also? Yes. Can bacterial infections present with low grade fever? So how do we know this is viral? This could be bacterial. So take this discussion further. What do you, if I am asking you that at this point, with this history of 7 days low grade fever, what do you make out?
Like because of some infection, child has fever, but focus would be anywhere.
Correct. So focus could be anywhere means do you think this could be acute tonsillitis?
Further, he has other.
Forget further. For the time being, don't take any other symptom. Just take low-grade fever for 7 days is what you have. So on 7th day, if you have to think of low-grade fever for 7 days, what will be your thoughts?
Back. More than 7 days. Good.
Bacterial. Okay, so I'm asking you, can it be acute tonsillitis? That kind of bacterial.
No.
Can it be acute lobar pneumonia?
No.
So what am I trying to hint at? That when I'm asking you that what do you make out of this low-grade fever at 7 days, you start by saying that commonly fever suggests infection. If this fever is infection, that if is a big if, then it is not a acute bacterial infection. I'm trying to say that because tonsil, pneumonia, all those are out. It is not acute. It's not high grade. They have not localized. Whether this is the beginning of clinical manifestation of chronic infection, you don't know at this stage, right? And otherwise, it could well be non-infective also. So I am just trying to make you understand that if you are asked to comment on low-grade fever at the end of 7 days, which is not even documented, these are possibly your thoughts at that point.
General symptom behavior as the child is important. Low grade fever child is okay. Is playful, is all right. Not very important. Constitutional symptoms. How is he? Is he low? Not only for 8 days, but earlier. These 8 days is little low, but he has not been doing well for last 15, 20 days. Then you can very well think of a chronic infection which is progressive. 8 days fever, but he's not doing well. We'll keep things in mind. But all is not well. If there's a low grade fever, however, if his constitution wise and he's not active, viral fever wala 8 day will not bother us. And also rising trend. पहले 2-3 दिन कम था, now it is worse. This is not a story of viral infection. 2-3 दिन ज्यादा था, अभी कम हुआ है. You are happy. Progressively rising fever, I think we are more concerned. So low grade has been more or less the same, or it's worsening or improving, or the same. Just wanted more or less the same. So we keep that in mind that it may be a chronic illness which is now coming to surface, or it may be just a low-grade illness, but it need not necessarily be an infection. As you said, not every low-grade infection. Keep our mind open. But all is well or all is not well? All is not well because he's not well.
I think low-grade infection has 2-3 possibilities. One, a low-grade subacute infection. Tuberculosis is one example. So that is one. And if it is so, then it may start localizing gradually, and we are not sure at that time what we are looking. Second is the low-grade fever just the perception of the patient and the parent? This child is small, young. So it's the parental possibly perception, and there may not be fever at all. But the third cause is some cellular damage in the body. It's not infected. One is subacute infection, which we don't know where we are. And one is an organ damage. So some organ is damaging slowly, and that is causing not severe. And I think at that stage, first 4 days, there is nothing happening. Because thereafter, vomiting came on. So first 4 days, I would have said, I'm sure it's not an acute infection, so not acute viral, acute bacterial, but I will keep open. So at that time, now has vomiting. Before that, or both together, vomiting 3 episodes only. And generalized abdominal distension was generalized progressive. What does that mean? So on day 4 of the illness, you are getting some localization. and localization in the form of abdominal distension. It's progressive. What is this progressive? Is gaseous distance? If it was gaseous, it was waxing and waning. So it's progressive. If what you said is exactly right, that means some mass is increasing and progressing. So increasing fast. Okay. And generalized, now it's a small child. As such, there is a little protuberant abdomen. It's not easy for parents to exactly tell you. The abdominal size is also not big. So we keep it open, but it goes in favor of some progressive swelling coming up. But it's not painful. There is no abdominal pain. So I know that on day 4 of the illness of fever, which was low grade, there is something happening in the abdomen. So you are localizing the disease in the abdomen. But you don't know what it is. It's partially progressive. But along with that, the fever is not worsening. The health status is not worsening. In other words, the local disease is worsening, but the systemic manifestations are not deteriorating proportionally. So now you say that it's a locally partially progressive disorder without much systemic deterioration. Now comes vomiting. Vomiting is non-specific, but if vomiting comes little later in the course of the disease, it's almost never GI. It's somewhere else. Now what is somewhere else? It's in the abdomen, so it's the liver. Okay. It's not CNS, it's not cough-induced, so it's liver. So that, but that may not be really the liver itself. Any fever or any abdominal distension itself might cause, because that probably is just 2-3 episodes. We may not give a lot of importance to it. And therefore, we know at this point that very likely it's the partially progressive liver disease. And why fever? The liver cells are getting damaged. Therefore, we start smelling there. Then comes the jaundice. And now we discuss why jaundice.
And just to keep you all thinking, can this be acute intestinal obstruction? Abdominal distension in 3-4 days and vomit. Very good. So no pain. What else? Constipation. What else? What are the hallmark signs of intestinal obstruction? And bilious vomit. Okay. So pick up on all that. The second thing which we wanted to keep you thinking is this, if this is right, then this abdominal distension has come up in 3-4 days. Which abdominal distension you have seen which comes up in 3-4 days? Ascites. So fluid in the abdomen is the only thing which can come up so fast. You can't have organomegaly coming up in 3-4 days. You can't have a lymphadenopathy coming up in 3-4 days. Enough to cause abdominal distension, right? And intestinal distension like obstruction we already talked of, right? So that's the other thing. So one, it's only ascites. Secondly, is it possible that this child already had liver spleen enlargement or something earlier, and now this child has developed ascites, and that's why they have noticed abdominal distension, right? So for that, what Karesar was saying, that how was this child before this is very important. Was he absolutely all right 7-8 days back?
Right, always, sir. Like intermittently, he was falling sick. Like he had 2 episodes of abdominal distension previously, also 3 months and 6 months. Then he was becoming all right for few days. Then again,
So 3 months and 6 months means 3 months back and 6 months back.
Like this episode was in April, so previous 3 months December and before that in September.
So that time also, what would happen? Abdominal distension, what else?
Abdominal distension was there, and mother was saying ki low grade fever was there, but it was for only 2 days. Then some investigations were done, and some symptom was only abdominal distensions.
Then it used to last how long and go how? How would it go?
Sir, she used to go to the within 4 days. 4 days, she goes to medical attention. Then within 2 weeks, it was normal before.
Acute onset of ascites is very unusual. So I will not go by that generalized abdominal distension line. But all that I know is a small infant. It's not easy to make out where is generalized, but I won't consider ascites at all. So, but something has suddenly come up in the last 4 days. Either it was there minimally and worsened, but then there is an acute worsen, which means it could happen acute for the first time also. And therefore, I still feel that is quite in favor of the liver enlargement. It may have been earlier there, it worsened. Now you have a recurrent episode of a similar nature. Now you add one more adjective to that, a recurrent illness, a recurrent liver illness, which came, disappeared for a while, and came again. At which time I want to know how well the health was maintained in between these episodes, which will tell me whether the disease was slowly worsening or the disease was not worsening. These are all important things to make out at 3 years of age, 3-year-old, right? As such, the weight gain is only about 2 kilos a year. Parents can't make out easily. So all these are that. But now we know recurrent. Now past history of similar history in the family. Add one more adjective, genetically determined recurrent liver. So what is recurrent? Immune or metabolic? So now only differentiate between the two. Immune could be recurrent, okay, and metabolic could be.
Sir, those past history of just distension for
No,
about two
jaundice.
weeks.
Complained about jaundice. No.
Okay. So that may not be. I thought past history of similar.
Not noticed by mother.
Yeah, maybe mother didn't notice, agreed,
But
but
there been no history of jaundice. No, I thought past history of similar disease. I thought similar means distension and all that. Okay.
it's a little odd. I think there is something missing in the history, but it's not possible that just distension for 2 weeks and then low grade fever and then would go away.
Unless the liver was there and that distension was some gaseous or constipation or and then your heart renewed. But surely it doesn't gel well. But I think even if you don't take the previous story, it looks like that partially coming. Which partially enlarging organ in the abdomen is, it's only the liver. Liver abscess very fast. Congestive cardiac failure very fast. Hepatitis could also be very fast. Okay, but this is not viral hepatitis. So this is autoimmune or metabolic. Okay. 3-year-old Wilson's.
Sir, it could be also like some acute infection has pushed him into like chronic failure or something. Matlab, it could be a acute viral hepatitis which pushed him in failure due to some underlying chronic.
The rule we will not rush in to call Wilson's in a 3-year-old, but surely it is still possible.
She's saying that maybe there was a chronic liver disease
Only
and
that-
this is a acute insult which has pushed him.
But he was not then normal. So that's again an important. If he was a normal child with all this, then he doesn't have a chronic illness. Okay.
Yeah, he wasn't normal. They are saying he was always unwell.
So
So
that's unusual. Silent liver disease is not metabolic. Okay, hepatitis B could be silent. C could be silent. But Disease like immune or metabolic is not silent.
Okay, then on second day of admission, mother noticed yellow discoloration and the child was preferring to sleep and was responding only to painful stimulus. So what do you make out of all this?
Encephalopathy. The child is not responding to stimuli, or there is irritability or persistent cry. So,
So acute hepatic encephalopathy, right? So he's gone in acute hepatic failure. Now, this unclear part from the history is whether it is acute on a chronic background or whether it has come up all of a sudden and it has gone worse very fast. But there is history of two such episodes in the past, but not with change in behavior, only abdominal distension, right? Okay.
Can it be acute hepatitis A who is progressing to liver cell failure? If you don't know the past, those acute hepatitis A who are progressing and going to hepatic coma always have a relatively high. They may have low grade fever and then they go for a high fever and then they go down. The fever doesn't remain low as normally one would expect. We have seen a few and they all had some bad and fever was rising. Only thing is occurrence of vomiting later on in an illness is always a warning sign. Like hepatitis or metabolic diseases, we can also. Distension of abdomen can be very non-specific. It can be there with any illness in the child. So something is going on, probably not infectious, but maybe metabolic is coming up. And what will be the occurrence or serial order of appearance of jaundice in hepatitis A? And suppose it was hepatitis A, what would the history be like? Low grade fever in the beginning, not doing well, okay. Jaundice appearing on day 4 and patient becoming worse or better. In the beginning, for 3 days, low grade fever, the child was not. Child, normally the mother may say, normally with high fever also when there is no fever is craved. If fever was coming, dilla pada, khata nahi. He has no appetite, is not active. And as the jaundice appears, he starts. आज ये दिख रहा है लेकिन आज थोड़ा मांगा, आज थोड़ा अच्छा. Occurrence of jaundice in a typical hepatitis A signifies beginning of improvement. Here it is the opposite. So hepatitis A by any infection, but metabolic, I think we will keep in mind.
The past history of hepatic disease and the neurology. And the present problem, again, possibly hepatic and neurology. So you have something similar, and therefore I will add a genetically determined disorder, not autoimmune.
Third degree consanguinity. Third degree consanguinity.
Rajesh, we cannot hear.
Hello.
Yes, we can hear now.
3 years old male child born out of third degree consanguinate marriage presented with fever, abdominal distension, jaundice in birth and developmentally normal child is probably a case of acute hepatitis with encephalopathy, probably a viral cause with underlying chronic liver disease. On examination, child was febrile with pulse rate of 120 per minute, rhythmic, regular, normal volume equal on both sides. Peripheral pulses were well filled, RR of 32 per minute, saturation was 98% on room air, BP was around 58 percentile, extremities were warm, icterus were present. On presentation, blood glucose was 40. Anthro-wise, he's normal for age. Weight 11 kgs, height of 86 centimeter, MUIC of 14, head circumference of 47, and weight for height between -1 to median. Head to toe examination, there was a periorbital edema with abdominal distension, icterus was present. On systemic examination, there was abdo-distension with umbilicus everted, liver of 3 centimeters, span of 12 centimeters, left lobe was palpable, firm with smooth borders, spleen was not palpable. CNS pupils were reactive to light, tone was increased on presentation. Reflexes were 2 plus, plantars were extension. Respiratory air entry was bilaterally equal. Cardiovascular examination was normal.
Was the liver tender?
No, sir, actually, it was not tender, sir. A 3 years old male child born out of third degree consanguinity presented with fever, abdominal distension, jaundice, and altered sensorium in birth and developmentally normal child with significant family history is probably a case of acute liver failure in hepatic encephalopathy with underlying CLD, probably due to metabolic versus mitochondrial versus autoimmune.
Any free fluid in abdomen?
Yes, sir, it was.
There was.
Yes. Yes, sir, it was. Didn't mention.
Huh?
It was there, sir. Fluid thrill was positive.
Fluid krill was positive. So lot of fluid.
Investigation wise, on arrival, his HB was 9.1 with WBC counts of 6,000 and platelets were 1,83,000. Within next day only, the HB was fall because there was bleeding episode. The child was intubated for altered sensorium. There was EP bleed and also episodes of melena. So child was transfused on HB of 7.5. This is LFT trend. These previous two LFT were from that 3 months and 6 months before, that is on September and December. At that time also there was some enzymes were elevated and TBL was elevated. Then in these episodes there were rising trends of enzymes. On arrival to our hospital, the enzymes were around 3,000 and 1,700. Serially, the enzymes are in dropping trend. And also the ammonia on arrival was 221. And on arrival, the INR was 2.9. So FFP transfusion were given. Next INR documented was 1.6. And hepatitis A antigen IgM was positive. BU and creat was normal. And USG findings, there was altered echo texture with ascites. And we traced the investigation of sibling. So there was one mitochondrial DNA deletion, which was hepatocerebral. We are planning to send genetic workup for this child also.
How is the elder sibling now?
Currently, sir, she is having that abnormal movements, but with medication, there is mild improvement present, but developmentally, there is regression of milestones. She is currently 7 years of age. Around 5.5 to 6 years, she started having those CNS manifestation. And her previous admission at the age of 3 years, she was also Hep positive. But she was recovered at that, and she was doing well before after that. But at the age of 6 years, she started deteriorating CNS wise.
Okay.
Hepatitis A positive looks more like incidental. That should not be the cause of this particular child going down. There's a past history also of this child only now. So there's a history in sibling. Previous child also hepatitis IgM positive.
Yes, hepatitis A, she was also positive.
Hepatitis
And
should
one,
be only incidental and should not be producing hepatic.
there are three siblings. Middle sibling is fine. She is normal. The first elder daughter and this son is affected.
You have ruled out Wilson's, you have done ceruloplasmin level.
Sibling was all Wilson workup was done, so it was negative. So when we did for this child, we only sent planning to send genetic workup only NGS.
Typical acute viral hepatitis should have had a very high level of insulin, right to begin with, even much before bilirubin. That hasn't happened here. Now, just to go by IgM and 9 point something, I'm not sure whether that means really an acute viral. But typically, an acute viral at 3 years is not common, number one. It presents often more asymptomatic, less symptomatic. Whereas here it looks symptomatic. Question is, it's certainly not the only cause. If at all there is some trigger which you can't deny, but you would not have suspected that kind of a trigger. Especially if the child was absolutely normal, then acute viral A coming up without much enzyme rise, jaundice coming out 4 days later is something unusual. And if you already got acute hepatitis on the top of chronic liver disease, then it should have even cleared up faster. So to that extent, and then hepatic encephalopathy. So we are clear that it was metabolic. It was not typical Wilson's, nor tyrosine. Tyrosine is hepatorenal. Okay, so that still comes in the discussion and a mitochondria. So I think mitochondria, the metabolic etiology reasonably right. Viral A, maybe investigation, why we won't know really.
Any of our online friends want to comment anything or ask anything?
Very, very unusual case and excellent presentation. Good discussion.
Okay, thank you. Any other questions?
Look at the bilirubins initially, 0.9 and 1.1.
So that was 3 months back. This 0.9 and 1.1 was 3 months back and 6 months back.
24 is too low for hepatitis.
Yeah.
824 is too low for hepatitis. And for severe, no. But it has gone up to 3000 once on 29. Somewhat quite low, 100 now.
Okay. Fine. So I think we'll stop here and next time tell us what is the genetic analysis. Video वर बोलायचं. Before we close, Dr. Iman Joshi wants to say something.
I want students to hear me carefully and repeat the history by your work. If this child had come in 1980s, a child from a good family, gets icterus, large liver, we would have diagnosed him as Indian childhood cirrhosis, and we would have prognosticated his death in small time. The children from all Indian good families, well fed with lot of cow milk, were dying. And we were sad about it. We could do nothing about it until Dr. Pandit and his team from Pune, they did liver biopsies and did dry copper weight and found out with help from UK panel that it was the copper poisoning that we unknowingly did by boiling milk in copper vessels and killed our parents. And then in 1986, Sharda and Bhandari proved that not using copper vessels eliminated Indian childhood serum. So work from Pune, then a conference in Pune, and then work by others. Eliminated this killer disease of Indian children. But why am I telling you this? There are so many problems which we do not see. Then how will you find solutions? So go beyond your narrow vision of your MD pediatrics, blah, blah. Have a larger vision. Look at problems, find out solutions, and change the world. In the, around 1990s, Hinduja Hospital did a study, serology for hepatitis A in Mumbai. And they said 95% of Mumbai children are seropositive for hepatitis A at the age of 5 years. Did you do, he was hepatitis A positive? Thank you.
These days, the case scenario has changed with mineral water, even 12-year and 13-year are hepatitis G negative.
Okay. Thank you, friends. And we'll meet next Thursday at 6 p.m. again. Thank you.